Hello, I want to welcome everybody to the first ever Rural Healthcare Symposium preview webcast. My name's Bill Bowling, and I'm the principal at Bowling & Company, and together with Mason Reed and Dr. Fazil Khan, a professor of law at the University of Georgia, we're happy to be able to bring you some very special panelists today who are experts in a number of fields. The first panel that Dr. Khan is going to kick off in just a moment is with experts in the Medicaid field. I do want to, before we start, thank WABE, who is our host here today in their studios. Also want to say a special thanks to Healthcare Georgia Foundation, who has made a grant to make this possible, and also Professor Khan and his colleagues at the University of Georgia, who team up with us on this. And Professor Khan, you want to take it from here?
All right. Thank you, Bill. And reiterates thanks to WABE for hosting this really timely and relevant panel on kind of the future of Medicaid. First, what I want to do is kind of introduce our panelists. We have Dr. Bill Custer, who's the director for the Center for Health Services Research in the J. Mac Robinson College of Business at Georgia State University, and he's a core faculty member of the Georgia Health Policy Center. Previously, Bill was a director of research at the Employee Benefit Research Institute in Washington, D.C., and before that, he was an economist at the Center for Health Policy Research at the American Medical Association. We also have Laura Harker, who is a health policy analyst at the GBPI, where she researches and reports on Georgia's health policies and related spending. Prior to joining GBPI in 2016, Laura was a fellow with the Congressional Hunger Center, conducting public health research, policy analysis, and advocacy on food insecurity and poverty issues, and also worked with the CDC conducting policy assessments and impact analysis. And we have Beth Stevens, who is a Senior Director of Public Policy and Advocacy at Georgia Watch, promoting their mission and promoting healthcare access through consumer education, policy development, and advocacy. Beth has worked as an attorney in the health law unit at the Atlanta Legal Aid Society and received the ADL's 2016 Stuart Eisenstadt Young Lawyer Award for advocacy work protecting Georgia's healthcare consumers. And lastly, we have Dr. Renee Waldrop, who teaches financial management for healthcare administrators at the Morehouse School of Medicine's Masters of Public Health program. In her 30-year public health career, she has managed multi-million-dollar projects at the local public health level, conducted large operational reviews, and consulted with healthcare agencies and community-based organizations to optimize their infrastructures. So thank you all panelists for being here today. So what I'm going to do is give a short description of the subject matter we're talking about, Medicaid. It's kind of briefly this history and where we see it going in the future and some of the big kind of policy debates. So the history of Medicaid, as many people know, and some people don't know, was that it was signed into law in 1965 by LBJ as part of this program to expand access to health care, which included the establishment of Medicare. So Medicare, of course, covers the elderly population, those over 65 years of age. And over time, Medicaid, there's been amendments to it by Congress to kind of expand the populations that it covers. So currently it covers low-income families, pregnant women, people of all ages with disabilities, including duly eligible Medicare recipients, and people who need long-term care. Now, in 2010, under the Affordable Care Act, also known as Obamacare, right, one of the provisions of the Affordable Care Act was to expand Medicaid coverage up to 138% of the federal poverty level. So Medicaid you can view as a contract between the federal government and the states, where the federal government gives funding if the states agree to go along certain conditions set by the federal government. However, in the 2010, this expansion was challenged by many states' attorney generals, primarily red states, and they argued that the conditions for expansion, which was you had to expand to this new level or lose your existing Medicaid funding, was too coercive. And a majority of the Supreme Court justices agreed. So the remedy was to make the expansion voluntary. So states could opt in to the expansion or opt out and not lose their existing Medicaid funding. So that brings me to my first question to the panelists. What do you think was the rationale, stated or otherwise, for the 18 states, including Georgia, that opted not to go along with the ACA's Medicaid expansion? Who wants to take a first crack at this? Renata.
Thank you. I think there were at least three, and there could be more, three main reasons that turned into rationale for these states. One of the first was the idea of state budget constraints. and the idea that basically the cost to the state to cover a large number of uninsured individuals that fell into the gap would put, a burden on the state budget. I think there was also the belief that at the federal government level, the guarantee to cover the cost of services starting at 100% and ratcheting down to 90% was something that the federal government was not going to be able to sustain. And I think many of them felt like the inability to sustain that kind of guaranteed payment would force the states to pick up the full cost of caring for those individuals at some point in time. I would say that the third rationale was likely the belief that the Affordable Care Act was going to be repealed and replaced, and I think that was particularly a rationale after the 2010 midterm elections. I don't think many folks really believed that the law would stay in place, but that certain portions of it, if portions of it stayed in place, certain portions would certainly be, abandoned. I would offer those as three.
I think that's right. I think I think there's a broader philosophical reason. This was a part of a broader opposition to the federal government in general and President Obama in particular, actually. The rationale they used doesn't make a lot of sense when you look at the dollars and cents in terms of the burden on the state government, the possibility of the federal government rescinding its promise. First, on the state budget, we anticipated beforehand, have seen afterwards that states who expanded Medicaid's state budget as a whole has done much better than states who didn't in terms of things they could cover, the dollars, the deficits they may or may not run. All of them have done better. So that rationale didn't really hold water. But the other part of the state budget is long term. As you mentioned, the federal government is going to pay 100% for the first 3 years and then ratchet down to 90% of the expansion population. What Governor Deal said at the time was that the federal government is going to buy us a steak dinner and we can't afford the tip. And what he meant was, we could afford the tip right now, but if you look at the history of healthcare over the last century, the costs have continued to rise faster than incomes. So that even if we continued to pay 90% by the federal, the state's actual dollar amount would grow over time. And his fear was that by 2030, this would become unaffordable.
So your impression as an economist at the state level is that states may missed opportunity to maybe grow another revenue source that's not coming from, say, their own taxpayers directly?
Well, they missed several opportunities, but just in terms of state budgets, yes. They clearly missed an opportunity. A lot of things that Georgia does for its citizens, behavioral health and other things, could have been funded by the funding of that could have been transferred to the federal government and actually benefited Georgia taxpayers. It's a correct statement to say that every Georgia taxpayer would benefit from Medicaid expansion. But again, there's a broader philosophical issue here that is really part of that opposition to Medicaid expansion.
Sure. Laura, what's your take on this issue?
I will add to that and agree with some of the differences in philosophical standpoint and also just some of the state budget savings that the state could have seen if we expanded not just all the federal money that would come in, which would be about $3 billion a year, but also savings to uncompensated care for hospitals, the hospitals that have to provide care to people without insurance. Those uninsured people would more likely have coverage under expansion, and that means more money for the hospitals. And so overall, you see some broader impacts to also the healthcare system broadly. And we know the healthcare system is a central part of our state, and that one hospital job creates 2 jobs in the economy. So it also would have a really strong impact on the healthcare industry.
Yeah, and Beth, what is your perspective on why states like Georgia did not opt for expansion?
Well, I think that all the points that my fellow panelists have made are accurate and my understanding as well. But I know that the Georgia Budget and Policy Institute, where Laura works, has put out some great numbers that show what we're losing by not expanding Medicaid. And as advocates, we continue to lift up those numbers and continue to try to make our policymakers aware of what we are losing out, because we are losing $8 million a day by not expanding Medicaid. And we have given tax cuts to certain industries and in different areas here in the state that could have more than made up for what the cost to expand Medicaid would have been to this state. So we, as advocates, want to put the priority on healthcare access, especially for our lower income population here in our state, and for our rural population, for folks who don't have another insurance option.
Yes, I want to build on that last comment made about the rural population. Have you seen any particular communities that have been disproportionately impacted by the lack of expansion within Georgia?
Well, I will say that debt due to medical expenses is significant nationwide and here in Georgia. The Atlantic magazine pointed out last year that medical debt disproportionately affects the South. 8 out of the 10 states with the highest rates of past due medical debt are in the South, including Georgia. And there were some really interesting numbers that came out of the Urban Institute, a study they did just in December called Debt in America, that showed that in many Georgia counties, more than 30% of the population has medical debt that's in collections. So even though we do have hospitals that, are providing uncompensated care, providing financial assistance, there are still people, who can fall through those cracks or who don't qualify, who may not have health insurance because we have an uninsured rate of 14%. 18%, it's even higher when you look at the non-white population in Georgia. And those disparities are giving rise to a lot of economic pain for Georgians.
Yeah. Do we see these disparities spread evenly across the state, or some communities, in your observations, have been hit harder?
The more, I'm sorry.
No.
The
Go
more
ahead,
rural
Dr.
the area, the harder the pain. And what Beth was talking about in terms of hospitals providing uncompensated care, for rural areas, that's a larger share of their total patient base. They don't have, rurality means you don't have the population base to spread those costs over the way you do in urban areas. So it's been estimated about 10% of rural hospitals are in danger of closing. And the bottom line is they don't have enough resources. And certainly Medicaid expansion would have provided additional resources that not just increase access to those people who now become eligible for Medicaid, but to all people in that area. Because if the hospital closes, everybody's either out of care or driving long distances, spending a lot of money to get
Yeah.
there.
And Renata, you wanted to say something.
I just wanted to add that, traditionally we're talking about communities and demographic groups that have traditionally always been uninsured, non-elderly adults, and what we always knew to be the working poor, which, of course, S-CHIP helped out for the children of the working poor, but that still left the adults, many of the adults, uninsured. And to go back to the issue, I think, of rural versus urban, and it's not just here in Georgia, I think it's nationally. Rates of uninsurance by racial makeup differ regionally. As we've talked about from the standpoint of rural communities, more white, non-Hispanic whites in your rural communities, in your rural areas, and in your Midwestern states. And mostly, if you will, higher numbers of African Americans and Hispanics across the South. We are the third, I believe, highest state with the highest rate of uninsured minorities and uninsured individuals, if you will, that from the standpoint of non-elderly adults. And many of those are African Americans, Hispanics, and your older white, non-Hispanic white individuals in your rural communities. So I think demographic-wise, that's what we're looking at.
Yeah. So it seems like certain communities have been hit harder, right? Rural communities, certain minority communities. And you also mentioned that at the institutional level, there's been a lot of closings in these rural areas. Where does Georgia rank in terms of rural hospital closures?
Well, actually, I don't have the final numbers, but we're real close to the top. again, because of all the things, the vulnerability of our population, the relatively low income, and the size of our hospitals. Frankly, we have a lot of hospitals that were created by the Hill-Burton Act that are very small and have a very small paying customer base, and that's just it's a recipe for closure. And other rural areas outside of Georgia have dealt with hospital closures in different ways. They've consolidated into regional hospitals. They've had urban hospitals reach out into rural areas. That is slowly happening in Georgia, but we are one of the biggest states east of the Mississippi, and just the geography prohibits some of that.
Yeah, I know down in south of Georgia, like in Albany, Phoebe Putney has taken over a lot of the local healthcare systems, and some hospitals like Cordeal, I believe, is kind of opted out, but they have one of the highest hospital cost of anywhere in the country. So we're seeing the impact at the individual and family level. Laura?
Yeah, I'll just add there was a recent study looking at expansion states and rural hospitals, and the study found that in states that did expand, their rural hospitals were less likely to close. And I think that's part of what you're talking about with the high cost. Medicaid expansion can help bring them more paying covered patients. It's not the only end-all be-all solution, but it is a big part in helping their budgets.
And the personal impacts from a consumer standpoint of all of this is how long does it take you to get to the hospital? Our maternal mortality rate in Georgia is very high, and it's something that we need to work on. And we have extremely high rates of chronic disease that people need to manage. So if they have to drive long distances to get to a healthcare provider, to get to a hospital, and we're not investing dollars in growing our healthcare system in a way that's going to meet consumers' needs, then we're not going to improve. We're not going to raise our state in terms of health rankings, and that's something that should be a priority.
Yeah, so it seems like lack of physical access in a lot of these rural communities obviously can have negative healthcare impacts. On the economic side, is that if you're a business looking to expand in Georgia, is that a consideration that businesses take into account, lack of, say, hospital access?
There's two barriers for Atlanta has a really strong, or Georgia in general has a really strong bid for attracting Amazon's new corporate headquarters, and there's two barriers to demerits, I guess, in terms of that. One is our transportation system, and one is healthcare. And while Georgia benefits from having inexpensive care relative to other states, the lack of access to care, certainly outside of, even within the Atlanta urban area, but outside of the Atlanta urban area, is a barrier to any type of economic development. And that's just the access. The access has consequences. The workforce and the health of the workforce is also an issue with Medicaid expansion or other methods for increasing health.
Yeah, I guess to add on to Amazon, the other big news with Amazon, the merger with J.P. Morgan and Berkshire Hathaway, just shows more of the concern from employers at looking at their health care of their employees and the cost of that health care and the accessibility of it in their actual community. Having good facilities around your business is important in attracting employees as well as keeping those employees.
Yeah. I want to switch gears and turn to the issue of kind of these Section 1115 waivers, which the states can present these demonstration or experimental projects to federal government and say, we want to be waived from the general Medicaid requirements. And the purpose of these waiver provisions is to allow the states flexibility in designing kind of innovative ways to deliver the Medicaid services. So in Indiana in 2015, Seema Verma, who was a top healthcare advisor to then Governor Mike Pence, now Vice President, of course, and now Seema Verma is the head of CMS, the Centers for Medicaid and Medicaid Services. In 2015, Indiana applied for a waiver to charge Medicaid recipients premiums. And we recently had a report and data that and part of the provision of the premiums is that if you didn't pay them, there'd be a 6-month lockout period. And a recent report said there's 25,000 Indiana recipients who've lost coverage under this provision. What is your general view of kind of waivers that are aiming to, one, charge premiums or co-pays to Medicaid recipients in order to, I guess, make them not overconsume or be more responsible? What's your general take on that? Renata?
I guess I would say that the first and foremost, we have to look at those 1115 Medicaid expansion waivers as workable alternatives. Yes, when we put some requirements in place, there are going to be portions of the population that are in some way, shape, form, or fashion not going to be able to meet those requirements. But there are going to be a large portion of individuals who will still remain covered and have never been covered before. I think the idea of waivers is good because it actually allows states some level of flexibility so that they can stay with whatever budgetary constraints they might have to actually put some provisions in place to support non-elderly adults in a Medicaid expansion program. But it also means that they have to be sure that they comply with the letter of the law. Not just the letter of the ACA, but in this case, the letter of the Medicaid law, and ensuring that they meet Medicaid's objectives and goals. So, there are some things that are being approved now that would never have been approved under the Obama administration. And I think what we'll begin to see is the floodgates opened for other states who have decided not to possibly expand Medicaid, but to actually look at how they might be able to do it under provisions that allow them to save even more or to, tiered premium structures, work requirements, those kinds of things. If this administration is true to its word, it's going to allow states to be so much more flexible in what they offer. And I think other states will come on board, but hopefully with the idea that there will be many people who can benefit from the flexibility that a waiver program can provide. That's not to say that the issue of requirements around working and other things, premium payments, it will be onerous on both the state administrative folks as well as the beneficiaries. Not knowing whether you're covered or you're not covered, whether you're locked out, whether you're in. It's going to be something that will take a lot of time and it will take administrative resources. I think that no state can right now, plan for.
Yeah, no, I take your point that in Indiana, where Governor Pence was then the executive, having the waiver allowed him politically say, okay, we're going to expand and cover additional 500,000 Indiana citizens under Medicaid, but with the possibility that some might lose it. In your mind, maybe that's a trade-off that has to be made in some of these more conservative red states.
I think it is a trade-off. You're going to lose some, but you're going to probably cover many more who weren't covered at all before. So I would say that that trade-off may have some legs.
Yeah, what you have to remember is that the expansion population is different from the traditional Medicaid population. Medicaid, as you said, was signed in 1965 as part of Lyndon Johnson's Great Society, as part of his war on poverty. The Medicaid program became separated from welfare under the Clinton administration, but it remains a program that is for low income, for people who are low income and something else. They're disabled, as you said, they're aged, they're pregnant women or children. In Georgia, there are no non-disabled males on Medicaid, regardless of their income. So the expansion population is different. And what it is it's transitional population. So there are people who, under the goals of the original Medicaid program, should be on it. They're sick enough that they can't work and whatever. And you'd attract those, but you're also attracting individuals, if you expand Medicaid the way the Affordable Care Act was written, who are working. Almost 70% of those who would be eligible live in families headed by a worker. So part of the rationale for some of these waiver programs is to help in that transition to private insurance, to mimic the characteristics of a private insurance plan. It is definitely a fact that in putting in any of those requirements, you are limiting the number of people who would pick up coverage. And that it will depend entirely on the details. I hate to, because you have to go deep in the weeds to see what the effect of a work requirement is, for example. Because states who have applied for work requirements, as you have to show you're working or trying to get work in order to get Medicaid, have applied that in a very different ways. They've had large exceptions. Students or people who have taken a health class are exempt. Well, that has a very different effect. But as Ronald just said, I think is real important, is that this is not, putting those kinds of barriers, those tests, is not free to the state. It is costly. So you said, well, we're going to try to, Kentucky wants to lower their Medicaid costs, but they put in these classes and these restrictions where you have to hire staff and they have to come up with enforcement procedures. You have to invent the class. You are spending state dollars to do that. So there are these trade-offs. I know I'm going long, but one of the things that many states have done, including Indiana, is that they have differentiated within the expansion population different populations on the basis of income and need, so that while they wanted a work requirement, they have a premium requirement. It's not on all those individuals who would be eligible on a Medicaid expansion. It's for the people whose family income is higher.
Well, I think, as Dr. Custer pointed out, it's the details that are really the tricky part of these waiver proposals. And for example, if you have a work requirement, what are the consequences of failing to report or having difficulty reporting? Are you going to get kicked off of the program? And if you get kicked off of the program, are you going to be subject to a lockout period where you can't get back in the program for 3 months, 6 months? And then what is the impact on the individual of not having access to health care for that period of time? I think you also, from an administrative standpoint, not just the red tape and the expense to the states in administering some of these requirements, but also for the individual, how easy is it going to be to report, and how well is that going to be recorded, and also how easy is it to enroll and become eligible and make your premium payments, and if we're using a managed care model, as we do in some of our other Medicaid programs, how well is the managed care organization talking to the state agency to make sure that everything is running smoothly? We've run into a lot of enrollment hiccups and challenges in that regard under our current Medicaid recipients. So those things can concern me greatly.
Yeah, I would agree. I think when you add some of these work requirements, co-pays, premiums, they end up being barriers to people getting covered and staying covered. And I would argue that doesn't meet the objectives of the Medicaid program, which is supposed to provide coverage to low-income people and to help them have care. So I think the more that those provisions are included, we'll see, as we have in other states, people losing coverage potentially. Of course, as you all said, depends on how the details work out. But really, the administrative cost is not worth what it could end up being with people losing coverage.
Go ahead, Beth.
Well, I was going to make a point about the exemptions too, and that was something I wanted to bring up in terms of, so maybe if you're a caregiver for another family member, or you are a student, you are medically frail or disabled in some way, but not eligible for Social Security or Medicare for whatever reason, you could qualify for an exemption and not be subject to these work requirements. But how do you demonstrate that you qualify for this exemption? What is that process? How difficult and burdensome is that for the individual and for the state? So that's another just sort of red flag with some of these.
I guess I would also add to the conversation the idea that many of the individuals that are on Medicaid, as Dr. Custer has pointed out, they are working, but they are working in service industry jobs. Mm-hmm. Many of them are working jobs where their work schedules and their hours are inconsistent. So if you put in a requirement that someone has to work 20 hours a week, and for some reason they don't get 20 hours a week, at this particular job, or maybe they work a few more than 20 hours a week. If they don't get enough hours to be able to work, they'll lose their eligibility because the work requirements say you've got to work this number of hours. If you work too many hours, you might still lose your work you may still lose your Medicaid because now you may no longer be eligible because you've worked more hours and earned more money, or it throws you into a tiered premium arrangement that requires you to pay a larger premium. I think the other thing that we have to recognize when we talk about work requirements is that Medicaid in and of itself has always been a safety net during recessions. Okay, so anytime we go into a recession, people who have lost their jobs have traditionally been able to just get on Medicaid to maintain their health, and their health status. I think with work requirements put in place, all of this becomes tenuous at best, and a lot to be thought about in terms of, as Dr. Custard said, the details and how are we really going to look at this.
Yeah, we talked about work mostly as some of the exemptions. Most of the other waiver programs have introduced programs that mimic what's happening in the private insurance market. So that's where you have the premiums, that's where you have health savings accounts and other types of things. The work requirement is in part just petty, actually, as opposed to meeting a health goal. That when Kentucky's waiver was granted,
this is last month.
The last month.
I'm
not sure title. The head of Medicare Services said, well, work has health effects. As if going to work makes you healthier. It's like I'll be a better golfer when I join the PGA. It's the causality is completely opposite. You go to work when you are healthy. If you don't restore health, you can't get a job. So I guess as we've all said, boy, the state would be better off with expansion and a work requirement than no expansion. But in that sense, this work requirement really doesn't make a lot of sense from a health standpoint or from an economic standpoint. Mm-hmm. Some of the other things, though, I think this is important in trying to understand how Medicaid works. Or how the healthcare system works. As a rule from Medicare to employment-based coverage to Medicaid, we are moving toward a system that measures health outcomes, that looks at population health, that moves away from the rural rescue, that is wait till you get sick and then we'll fix you, to a world where you help individuals adopt healthy habits and lifestyles and manage their care. That requires a continuous source of access to care. The care is different. It's, you don't wait till somebody goes to the hospital. It's primary care mostly, but it requires that. So when you put in rules that bump people off, you are moving toward a less healthy population. You are bucking the 21st century trend of the way the healthcare system is going for all of us.
Yeah, so the care is more disjointed, and if there's gaps, then maybe they're relying on more kind of catastrophic care, which is more costly and less effective. Just going into a little more detail on kind of this work requirement. So 9 other states reportedly are interested in getting similar work requirements. And as Renata said, like the requirement in Kentucky is that you have to show that you're working for 20 hours if you're quote unquote able-bodied. And recently, as of last week, there's been a lawsuit against Kentucky saying that this is that CMS can't do this under the statutory authority given to them by Congress. What do you think will be the outcome of that lawsuit? Does CMS have this authority to grant these kind of work requirements?
Well, I'm an economist playing a lawyer, so I'm happy to do that. This is the first waiver of all. There are many kinds of waivers that states could have applied for. Could have applied for since the beginning of the program to alter the Medicaid program in a variety of ways, go to managed care, have a new population. This is the first one where the waiver application said we are going to recover fewer people as a result. Mm-hmm. And so you could argue that is against the statute, against the certainly against the purpose of the law. And again, that's why the response from the Health and Human Services was to try to justify this requirement as increasing health, even though there'll be fewer people getting care. And I think that argument doesn't hold up to scrutiny. So, but on the other hand, what courts do is a mystery to me.
So Beth, I'm going to turn to you as the other lawyer in the room.
Thanks. Yeah, I know that a couple of national advocacy groups brought this suit. The National Health Law Program, Kentucky Equal Justice Center out of Kentucky, and the Southern Poverty Law Center. So it'll be really interesting to watch this and see where it goes, and see how these work requirements are going to hold up in court. Now that we haven't seen these requirements approved under past Republican or Democratic administrations. So it's a new frontier, and that's why the challenge was brought. But I think also, they were challenging a lot of things in the Kentucky waiver that are, concerning to advocates, including work requirements, premium requirements, including waiting periods and penalties, emergency room cost sharing, lockouts with penalties, waiver of retroactive eligibility, and also waiver of non-emergency transportation. So it'll be, there were a lot of different elements to that case, and it'll be interesting to see how it turns out.
Let me add that going back to Kentucky, as Dr. Custer said, they've identified the fact that they will lose enrollees. They, in fact, expect to lose 3% of their Medicaid enrollees every year. Exactly. Yeah. Every year, and up to about 15% for the first 5 years. But I think what we also have to realize is that, for instance, CBO scored Graham Cassidy. Okay, and what they noted was that many states will actually implement these kinds of work requirements and other provisions simply for the fact that they can reduce enrollment and thus reduce the associated cost with those programs. So I think those are other things that are going to come out, from a legal challenge perspective, that Beth has talked about as the repercussions of work requirements become known to us. We're going to have a lot of legal challenges to the issue of work requirements because they simply don't stand up to the goals and objectives of Medicaid as a program.
Yeah, I want to switch gears and turn to the issue of kind of block granting, which is when the federal government can give fixed amount of money to the states for a specific purpose. And in March of last year, House Speaker Paul Ryan said the following, quote, and this is at a panel where he's with Rich Lowry, the editor of National Review. He said, so Medicaid, sending it back to the states, capping its growth rate. We've been dreaming of this since I've been around, well, since you and I were drinking at a keg. Setting aside that this might possibly be the worst keg party ever in D.C. history, what does it say? What's your impression that if Medicaid was turned to a block grant program, what would happen to this the population it covers long term?
I think the block grant is really another way to think about it is a cut to the states. Because with the block grant, as you mentioned at the beginning, right now the federal government gives us a matching rate based on how much the state puts in. But under a block grant, we would get a set amount. It wouldn't matter if we put in more money or if there's an emergency crisis, an epidemic, the state needs to spend more. All of those extra costs would be put on the state. And so over time, you'd see the federal funding, the total funding to the state cut drastically. And that would really lead to cuts in enrollment, potentially additional requirements like premiums or work requirements that would draw down enrollment because the state wouldn't be able to keep up with those costs. So it would be a challenge for the state budget for sure.
So the birth of the Medicaid program, it was decided to do a matching grant to the states. And that match it means that when the state puts up $1, the federal government puts up between $1 and $3 for each dollar the state puts up. And it was designed in a way to help lower income states have faster growth in their health care facilities and in access to care. So Georgia gets about $2 from the federal government for every dollar they put in. Going to a block grant undercuts that in a big way. It means that wealthier states benefit and poorer states lose. And of course, not expanding Medicaid factored into the calculation of that block grant. But it really means over a long term the Medicaid program goes away. The states with the lower income have the least resources to put towards any type of program like this, and healthcare in rural Georgia would just, as we've heard, eligibility would have to be cut. There's only so much you can do to lower cost. You can reduce the payment to providers. Georgia's already one of the lowest payers in the nation to providers. You can reduce the number of services you cover, and For example, there's been proposals in the past to the legislature to remove pregnant women above a certain income from Medicaid, which means that they're not going to stop being pregnant. Somebody pays those costs, or you lower the number of people. And so the easiest for a politician is to restrict access till eventually it goes away.
Yeah, I know one of the proponents of block granting talk about the flexibility to the states and turning a lot of the control of how they design their program over to the states. But that flexibility isn't worth very much when you don't have the funds to fund anything innovative. From an advocacy standpoint, the concern is, does that flexibility mean it'll result in a reduction of people on the Medicaid rolls? And I think also we are one of the lowest states in terms of Medicaid expenditures per enrollee. And so when you look at these federal proposals, how is Georgia's block going to be determined? Is that going to be determined on current expenditures in Medicaid? Because if so, we're going to lose out compared to other states since our per enrollee expenditures are so low. And so it will enshrine some of the disparities that exist in the Medicaid system across the country, and that's a big concern.
So I want to turn to the issue of kind of Georgia politics. So we have, I hear, a governor's race coming up, election, and it seems that on the Democratic side, the two Stacey Evans, Stacey Abrams, have both said that they're in favor of Medicaid expansion. Now, on the GOP side, I believe Lieutenant Governor Casey Cagle said he's not in favor of expansion, and I'm not sure what the whole host of other candidates have said on the GOP side. But do you think they might follow the example of, say, Kentucky and Indiana, where they might go along with expansion with certain type of 1115 waivers? What's your thoughts on that?
I think the long-term goal of Lieutenant Governor Cagle and some of the other Republicans in the House and Senate here is to probably look at adding some of those work requirements and premiums. We saw with the Chamber of Commerce plan that was proposed in 2016, some of those provisions were included. And that kind of, the language about having skin in the game and flexibility was really big as part of that proposal. I think in the short term, we're seeing a proposal of narrow types of waivers. So some state leaders may look at applying for Medicaid waiver just for targeted services for people with behavioral health conditions or with opioid abuse challenges. So we're seeing some of that, as well as some proposals around delivery system reform within Medicaid. So I think we'll also see some talk about those types of waivers too.
I sort of think that this will happen faster if we wind up with Democrats in the governor's office. It'll wind up, I think, a lot slower if we have Republicans. But I think we will get there. It may be years before we get there, but I think we'll get there because there are more advantages, as Dr. Custer has pointed out in many of his writings, just from an economic perspective, why we should be expanding Medicaid. We are one of the few states that's giving up our Medicaid expansion dollars to other states that are growing well under Medicaid expansion programs. I think that there are going to be enough different provisions, that we can look at, that we can adopt, that will allow Georgia to create an 1115 Medicaid expansion waiver program that meets the budgetary constraints and requirements. I think it's something we're going to have to do, or else we are not going to have, as Laura has just said, skin in the game around a lot of things. We'll lose out, as Dr. Custard mentioned, around new industries and new businesses wanting to come to Georgia for some of those very reasons. So I think, if the Democrats get in, then we've got a shot that's just a lot shorter in its time frame than if the Republicans get in. But it's going to happen sooner or later, I do believe.
What the Chamber of Commerce tried to do is put together proposals that would fit what they heard Georgia policymakers wanted. And some of that was the demonstration waivers, 1115 waivers we heard. The Affordable Care Act also has what's called a 1332 waiver, which allows states to combine all of the money that the Affordable Care Act brings into the state to create increased access to care in a variety of ways. what the Chamber's task force did was look through a lot of different options and cost them out, and basically showed again the economic benefit of expansion and dollars to do it in a way to go forward budget-wise. I, being a terrible politician, I understood as that process was going that most of the policymakers in both the legislature and administration were contemplating enacting what the Chamber had put together, or at least using that as a base for some legislation. I think the election of the President Trump changed that political calculus, and again, I shouldn't make forecasts politically, but I have said since 2011 that every state will expand Medicaid eventually. When we look at what happened in 1965, it took 16 years for Arizona to finally join the traditional Medicaid program, but they're all there. And of course, Arizona was one of the first ones in on Medicaid expansion this time. And it is because eventually economics win. I mean, the politics are momentarily and have other issues that distract it, but the economics are just too good.
Yeah, I would agree with everything that everyone has said. And I just want to plug the Cover Georgia Coalition, which is a coalition of different advocacy organizations, and individuals can take part in that also at coverga.org. And there's still a huge movement to expand Medicaid, even if that's in the form of an 1115 waiver here in Georgia. We remain, like Dr. Waldrop is, optimistic that this is going to happen. Sometimes we feel like we're closer than we are, and we hear a comment made, from a state leader that feels like a bit of a setback in that movement forward. But I do think, as we've all said, that it's an economic inevitability that we're going to need to do that as if it continues to remain an available option to expand Medicaid eligibility in Georgia. So, yeah.
What do you think the impact of some of these potential cuts to Medicaid, either through, say, block granting, limiting the federal funding, would have on long-term care? Because I think in the public perception, a lot of people view Medicaid as just lower income individuals, often minority. I think that's the way it's coded, at least in D.C. I've been there in the past year. Whereas most people don't realize that 2/3 of Medicaid spending actually goes to the disabled and long-term care. 60% of nursing home funding comes from Medicaid. And as the American population is getting older, do we need to look at different ways of funding what seems to be kind of necessary care for our aging population?
Well, you raise a great point. Traditional Medicaid has been the only financial means for most people on long-term care. There's a stylized spend-down model that financial planners use to help people go through their retirement, noting that eventually you're going to spend down your assets if you need long-term care, and you're going to go on Medicaid. And that's a big bulk of Medicaid, of traditional Medicaid expenditures. And again, we've been talking about expansion, which is a different population. But the block grant idea struck directly at the disabled and the aged because it was going to restrict the financing for those services. And there certainly is a whole generation of a certain age who are moving rapidly towards the high need for long-term care services, and there's no other way to finance it. There's two ways: personal savings and the Medicaid program, and that's it. Playing politics, the repeal of the Affordable Care Act fell on this exact point, the block granting of Medicaid. There was almost unanimous across state governors that this was going to be a bad idea for them, or okay if as long as we up the block to a point where we never run into trouble while I'm in office. So I really think that idea it made little sense for majority of Americans. I don't know that it's going to be something that we're going to talk about in the future politically. Other things are going to take precedence.
Yeah, I was just add with long-term care with looking at cuts to Medicaid. One of the biggest concerns we had with that was that it would affect some of the optional services, such as the home and community-based services waivers. These are waivers that help people with disabilities get services in their homes, like home health aid services, supports. Some programs also provide home-delivered meals. And so these programs are really important for people to continue to live in their communities, and it's long-term, as you said. It's not something that just is going to go away and that we won't need to spend on. But without the sufficient matching mechanism that we have now, if it's a block grant, if it's a cap, it'll be hard to sustain those optional services.
I would just throw one more thing out there that I think we need to consider, and that's the idea that through the tax bill that was just passed, we repealed the individual mandate for health care. I think this is going to place us in a situation as we get down the road of going right back to where we were pre-Affordable Care Act in terms of a higher number of uninsured individuals, higher costs to provide care, and things that could certainly just crop up again. When we talk about amenable mortality, for instance, the U.S. out of I think it's about 17 OECD countries, we have the highest amenable mortality rate than any of those countries. And we're going to move back to that. We're going to move back to a situation where individuals are not covered, they're not getting the care they need for chronic diseases, and there aren't going to be enough people paying into the system, okay, to allow us to afford the care that all the individuals that we've talked about that will be, taking advantage of the system in older age, the baby boomers and so on and so forth. The money's not going to be there. So I think we're going to be looking at another set of issues, that have been brought about by the repeal of the individual mandate and take us right back to where we were pre-Affordable Care Act.
Well, thank you. We're near the end of our time for this panel, but I want to once again extend a thank you to our panelists, Dr. Bill Custer, Beth Stevens, Laura Harker, and Dr. Renee Waldrop. And we're going to take a short break and transition to our next panel, which will focus on behavioral health solutions for rural populations. Thank you.
Thank you.
Can you hear me?
Yeah, can hear you.
Great, and I can hear you. We've got a few other callers that we're waiting to have
Yeah, okay.
So if you just say, once I bring them in, you may have to hit them as well.
Okay, sounds good. Yeah, take care.
Hey, Glenn, can you hear me? I can hear you, yes. All right, and Ron,
Yeah, I'm here.
great,
Okay.
thank you.
Yeah, I can hear you.
I am.
Okay, no, that's fine. Okay, very good.
Fine.
Hello, this is Bill Bowling. We're back for the second part of our Rural Healthcare Symposium, and we're focusing in this section, or in this session, on behavioral health and mental health in the rural space. As you know, if you joined earlier, I'm the principal and founder of Bowling & Company, a healthcare law firm and a healthcare consulting firm that focuses not exclusively but primarily on hospitals, physicians, and other providers and technology companies that are working in the rural healthcare space. I'm going to take a quick moment and introduce today's panelists, and then we're going to go pretty quickly into what I hope will be a conversation between really renowned and highly qualified experts. First, we have Dr. Ron Manderscheid, who is the Executive Director of the National Association of Rural and Mental Health. He's the Executive Director as well of the National Association of County Behavioral Health and Developmental Disability Directors. And he's an adjunct professor at the Department of Mental Health Bloomberg School of Public Health at Johns Hopkins University. Ron has had numerous leadership roles in the mental health field, including with the U.S. Department of Health and Human Services, and he's authored research and texts on serving people with mental illness and substance use conditions. We actually had the privilege of meeting him at the Jimmy Carter Center here in Atlanta. Dr. Sarah Vincent, who is across the studio table from me, is a triple board certified child and adolescent adult and forensic psychiatrist. She's an assistant professor of psychiatry at Morehouse School of Medicine and adjunct faculty member at Emory School of Medicine. She's currently serving as the president of the Georgia Council on Child and Adolescent Psychiatry, and she's worked in a wide variety of mental health treatment settings, serving disproportionately traumatized communities, and lectures nationally on working with trauma victims. Dr. Glenn Thomas is the CEO of the Unison Behavioral Health Community Service Board based in Waycross, Georgia. He is the chair and the Data Analytics Committee, chair of the Data Analytics Committee of the Georgia Association of Community Service Boards. He has taught at the University of Stirling, Bucknell University, and the University of Birmingham in England, where he was eventually named the head of the School of Psychology. On leaving the University of Birmingham in 2001, he was appointed Emeritus Professor of Psychology and came to the U.S. to join his wife, Sheila, who was working in Georgia. And we're very fortunate to have these guests today. We may be joined, although she's not on the line just yet, by Senator Renee Unterman. Senator Unterman, as you know, is a senator from Gwinnett County, and she's very busy today at the General Assembly, and she told us she's going to make every effort to step out, but we can't count on her. But I did want you to know that she's been involved with this panel, and she serves as chairs of the Senate Committee on Health and Human Services and the Appropriation Committee Subcommittee on HHS. She's a nurse by profession, and that's why she's taken such an interest in healthcare issues. And Senator Unterman has concentrated on healthcare policy during her tenure in the Senate. She's especially focused on serving seniors, children, and disadvantaged Georgians, and was named the 2016 Legislator of the Year by the Georgia Public Health Association. What we'll do is start out. Two of our callers are calling in today, and so I'll pick on them initially just to make sure we get in the flow with them. And I'll start with Dr. Manderscheid. Dr. Manderscheid, one of the issues that we came up in our preliminary discussions getting ready for today's panel is the fact that Georgia is the largest state geographically east of the Mississippi River, and there are tremendous issues with just the basic physical access to care. Right. It's aggravated, of course, in all settings, including urban settings, by a shortage of providers. But in Georgia, this challenge is multiplied by the great distances involved and the relatively sparse number of clinics and other communities. What are you thinking these days? What are you seeing as ways to try to address this major challenge?
Well, first, thank you very much for inviting me to participate. I think the topic that you're taking up today is a very, very important topic. And in the behavioral health field, I think what the headline would be is behavioral health traditionally has been pretty much an urban discipline. So if you're in New York or Chicago or San Francisco, you can probably get pretty good care. If you're in rural Georgia or rural Iowa or rural Mississippi, you probably can't, basically. And we know through statistics that NACO has collected that about 85% of the counties in the United States have either inadequate or no mental health services. And I know from having worked for a long time with the Carter Center that some of these deficiencies also exist in Georgia in terms of the capacity of the system to reach out into some of these rural areas. And the problem you're dealing with, we need to characterize that as well, is a large problem. So in any given year, about 25% of the adult population of Georgia will have some type of a behavioral health condition, and from anywhere from 4 to 6% of that population will have what's called a serious mental illness or a serious substance use condition, meaning that this affects their ability to interact in their family, in their community, in their workplace, in their school. In addition to adults, you have another 20% of the children in Georgia who who are exposed to these behavioral health conditions, and anywhere from about 9 to 13% are serious. And the bigger the percentage of children in poverty, the bigger the percentage of children that suffer from these conditions. So you have two things coming together. You have a very prevalent disorder, and you have a service system that has difficulty reaching out into rural areas. Some of the things that we have talked about as tools for this, obviously, how can we use technology to expand the capacity of the system we currently have? How could we use technology to expand the capacity of the community service boards in Georgia to better reach some of these rural people where you have these large distances and you have too few providers and so on? And I think, there's going to be progress made in expanding the capacity of the internet, high-speed internet in rural areas, which would be a requirement for doing that type of telemedicine in those areas. But I think it shows a lot of promise, and we need to keep lobbying to move the agenda on that. Another tool that's very important in these problems is expanding our capacity to have peers in these rural areas actually work with people who are actively mentally ill or actively in a substance use condition. And peer support has grown dramatically throughout the United States. In fact, Georgia was one of the founding states for extending peer support coverage through Medicaid to the population. So I think, that's another tool that can be used fairly effectively in rural areas. As you go up the continuum here, another problem, I was just at a session a couple days ago looking at the problem of aging and rurality. Well, in aging and rurality, there's a huge problem of social isolation of people. And a lot of the discussion in that panel was also about the need to build communication networks in these communities for children and adults with these behavioral health conditions. So we create, in effect, a social support network for them as well. So those are a few ideas that I think are getting legs at the present time and would be happy to discuss further here.
That's excellent. Let me ask Dr. Glenn Thomas to comment on some of the points you made about the special challenges of rurality. He's down in Waycross, Georgia, and has his community service board covers a wide swath, many counties in his service area. Dr. Thomas, if you would respond to some of the statistics and other ideas that Dr. Manderscheid has laid out there for us in terms of what you see with boots on the ground trying to deliver these services in your communities.
Yes, Dr. Manderscheid set out the picture very well and described the challenges. We serve a service area of about 4,500 square miles that have only a 155,000 population. A lot of it is very scattered in rural communities. In terms of the solutions, I think that certainly the technology is very important. To have good broadband is very, very necessary for telepsychiatry, but it's also increasingly necessary for things like maintaining electronic health records, which very often these days are cloud-based. So clinicians need access to the internet to be able to do their work. And finally, I think technology may well offer some ways of dealing with manpower issues, manpower shortages in this field, as we get to sort of tech-supported services. And again, this will require good broadband access. From what we've been trying to do over the last 15 years or so that I've been working in South Georgia, one of the things that struck me as being crucially important is trying to maintain a clinic in every small community. Although these are very likely to be uneconomic, and there's an awful lot of financial pressure to save on costs, but nevertheless preserving these clinics is, I think, very necessary given the lack of public transportation and the difficulties that people face getting around. Just to sort of paint a little picture, we've got a county of 7,000 people, and if we close the clinic there, the residents of that county would have a journey of upwards of 30 to 70 miles to get to our nearest next clinic. They often don't have vehicles that are reliable enough to make that trip. There is no public transport, and rely on friends and neighbors to give them rides and probably pay them gas money in return. These kinds of difficulties, I think, mean it's essential to try and maintain a presence, a clinic presence in a small community like that. And in addition, of course, the mental health service and the substance abuse services that we provide are often very much connected with law enforcement. And so if you don't have a clinic in a small community, you're not going to have a connection and a relationship with the local sheriff's office or with the local police department or the local Department of Family and Children's Services. And those connections are important to maintain the sort of wraparound of services that people with a mental health or substance abuse issue so often need.
Well, that's fantastic. I tell you, I'm turning to Dr. Sarah Vinson with this next question, and they've really made it difficult on you, Dr. Vinson. I think we've got two. You're our expert on the clinical. You're actually the person who's caring for these patients. So you have maybe the most important perspective on all of this, and I'd like to hear how you respond to this question of access, and particularly in the rural space that Dr. Manderscheid and Dr. Thomas have outlined for us.
Yeah, I think it's going to be important for all of us to think outside the box a bit. So I was really glad to hear it mentioned about the use of technology and those sorts of things. But even taking a step further back, I was glad to hear the mention about poverty, right? Because we know that, especially with kids who often are too young to have come down with bipolar or schizophrenia at the same rates that adults do, trauma, poverty, neglect, all of those are big drivers of mental illness. And so if you can find ways to support the community, to support the mothers, to support the families, that is mental health prevention. And I think in some ways, rural communities, that's a relative strength to urban areas sometimes. That those communities may be tighter knit, that you may have opportunities there. But I don't think that enters the conversation around mental health perhaps as often as it should.
Well, let me ask you to expand on that, and it sort of will segue to our next area of discussion, which is the relationship between behavioral health and primary care, questions of integration of prevention, education, population health management with actually responding to frank and acute problems. So how would you speak, or what are you thinking in terms, and Dr. Manderscheid mentioned, for example, Georgia's innovative use of Medicaid funds for prevention. What are some of the solutions you would see that could be drivers, or as you say, thinking outside of the box? How could we think outside of the box and begin to approach a more effective prevention, education, and population health management in this area?
I will say that within the professional community, particularly in the pediatric space, there is an appreciation for the need for integrated care. And the reality is that patients are demanding it because there aren't any child psychiatrists around, there aren't any child psychologists around. So they're showing up to the one provider they know, which is their primary care doctor. And so primary care physicians are already doing integrated care because they have to, but we need to do a better job in terms of supporting them. And what we've seen happen in Georgia is really remarkable. The professional communities have kind of taken it upon themselves to kind of fill in the gap where they may not be supported at the state level or by the way hospital systems are configured. So, currently there's a collaboration between the Association of Pediatrics and psychiatrists in the Georgia Council for Child and Adolescent Psychiatry, where they are doing webinars, where they're doing case presentations, where we're reaching out and educating. But this is all the physician organizations funding it themselves. And so I think for this to be sustainable, for this to be something that grows, we're going to need more people to help us kind of keep the ball rolling and support that infrastructure. And right now, you can get reimbursed for providing care to a patient, but I can't get reimbursed for talking to my pediatric colleague about how to do that. And until we're able to do that, we're going to keep relying on these pilot projects that aren't going to meet the needs that we have.
Dr. Thomas, I know you particularly have had some thoughts about reverse integration of behavioral health clinics being able to take on physical and primary care. Speak to us about some of the opportunities that you're seeing for enhancing the delivery of care by better integration.
Yes, I mean, this is very important. I mean, I'm sure a lot of you are aware of the shocking discrepancy in life expectancy between people with mental illness and people who don't have the challenge of a mental illness. And a lot of it, they don't die from schizophrenia. They die from, usual physical causes, but they don't take care of themselves. I'm very concerned about the seriously and persistently mental ill population, who often, sometimes have Medicaid, but do not seem to get good physical medical care in addition to psychiatric care. I would like to see CSBs enabled to provide primary health care in addition to the mental health and substance abuse services that they're authorized to provide under Georgia statute. That would need to come with funding for the uninsured in particular. Probably the majority of our clients in our mental health and substance abuse clinics here in rural South Georgia do not have insurance. Obviously, a sizable proportion have Medicaid, and it's those uninsured who probably need the primary health care added into their mental health care services.
How do you, just before I'm eager to get Dr. Manishai's view of these questions from an overall perspective, but what are the barriers to that sort of integration as you see it, and what are the potential catalysts to provide rapid solutions?
Well, let me take a step backwards and say a lot of effort has gone into try and bring mental health care, mental health screening to people who are already getting primary health care. I think those are the people that Dr. Vincent was referring to. They're the patients who are going to the federally qualified health centers who are now being funded to add perhaps a licensed counselor or a licensed social worker to do a mental health screening and get these people connected up to mental health services. The problem that I see is that the clients who come to community service boards tend not to go to those clinics, and without insurance, clearly there's a problem of people getting reimbursed to serve them. So I feel that our particular population will only get primary health care if it's provided within the setting in which they get their mental health care.
And what's preventing that from happening now?
I think some of it is funding. Community service boards would require a change to the Georgia statute that authorizes them to provide services to include primary health care. And there would also need to be some funding for the uninsured, which comprise the majority of our population.
Dr. Manishai, with your national overview of all of this, how are you seeing this unfold effectively or less effectively in different parts of the country?
So I agree very much with the comments that have been made. I did the research on life expectancy that showed that public mental health clients actually live about 25 years shorter life than other people, but they die of the same things other people do for the reasons that Dr. Thomas indicated, that they simply don't get the primary care they need. When they have high blood pressure, it's never treated, these types of things. So I agree that there's a very strong need to bring primary care services to that population. And there's been a lot of movement on the policy of integrated care nationally, some movement on the actual practice of integrated care, in both directions, moving behavioral health into primary care and moving primary care into behavioral health. But one of the limitations has been, as Dr. Thomas also points out, the lack of resources to do this. And I want to point out a couple of things. I want to point out a particular feature of the Affordable Care Act, Section 2703. Section 2703 is a program that a state can apply for, the purpose of which is to actually build the infrastructure for health homes in a state Medicaid system. And it provides up to 2 years of funding, and it covers a range of activities, including infrastructure such as IT, care coordination, and so on. So one potential opportunity here would be to explore Section 2703 and see whether that could actually be used to fund some of the things that Dr. Thomas is talking about. I think another need in Georgia, to round it out here on that side of the issue, if Georgia were to do the Medicaid expansion, then it would get a large influx of funding to some of the people who currently don't have coverage. So they literally are too poor to have health insurance, and the safety net in Georgia isn't strong enough to actually cover them through the state Medicaid program, so they fall through the cracks. And I know from work we did in Massachusetts, people with mental illness and severe mental illness are the hardest people to get covered with insurance, and they're the hardest group to keep covered. Currently in Massachusetts, that's had mandatory insurance for almost 10 years now, about 4% of the population remains uninsured, and 3.5% of that 4% are people with mental illness. So I think there's strong need to do the Medicaid expansion in Georgia to cover those people who are falling through the cracks of these various systems. I don't know where that stands currently, but I think it's a very high priority as well. I'll mention one other thing, and then I'll be quiet here. So in terms of doing the kinds of integration that Dr. Thomas is talking about and Dr. Vincent is talking about, there is a strategy called the ECHO program. The ECHO program is run out of the University of New Mexico, and the purpose of the ECHO program is to bring expertise to people who are dealing with difficult cases, who don't quite know how to solve those issues. And so what you get in the ECHO program is an expert in, let's say we're dealing with people with bipolar disorder. I believe that group has been mentioned earlier on the call here today. And you have a provider that's having, a person has refractory bipolar disorder, meaning they're difficult to treat. The provider can plug into an expert in that area who literally will walk the provider or a set of providers simultaneously through care of people who have difficult conditions, such as adults with serious mental illness that Dr. Thomas was talking about. And I know that the ECHO program is supported by the Federal Substance Abuse and Mental Health Services Administration, and that tool also would be available to help move the agenda that Dr. Thomas was talking about here.
Let me ask you, and this is a question for anyone on the panel that might have an opinion, and this is a very self-interested question. We represent community hospitals as one of our primary client bases, trying to stand them up and frankly help them get back in the black and continue operation. Georgia's tied for third in the country, last time I looked, for the most hospital closures. It seems to me that there should be a way of overlaying the need for this kind of care with the current extra capacity that many rural hospitals have experienced as their enrollment has declined. Are any of you aware of how community hospitals in rural settings have been able to step up and participate either in some way to expand service area in their communities?
So let me respond first, because I have, I think, an immediate example of this. So to the very population that Dr. Thomas was talking about, which are adults with serious mental illness, there were serious problems. This is not in a rural area, but it's the same concept in Portland, Oregon. And so I believe a set of 5 hospitals in Portland, Oregon got together and say, we need to work with the community service system in serving this population better than it has been served. And Portland, like many cities, has a large homeless population, a significant portion of which are people who are adults with serious mental illness. They also have a fairly large population of adults with serious mental illness that are cared for through the county behavioral health systems in Oregon and so on. And so the consortium of hospitals put together a program that works very closely with the community mental health services that are provided through the counties to bridge between primary care needs and behavioral health needs of that population. Now, that program is not very old. I would say it's somewhere between 6 months and a year old, but it's shown a lot of promise in that time, and I think represents an example of what you are driving at in your question here. One other concept I would add here is another thing we are seeing is the creation of what are called URGI behavioral health centers. So URGI behavioral health centers are facilities that exist somewhere between a community mental health center and a hospital, totally open. People can walk in on their own. They can be brought in by a relative, by a peer. They can be brought in by the police. They don't keep any appointments, and they are very short term. They're 23 hours and 59 minutes to not run afoul of the Institution for Mental Disease requirements. And they, too, are entities that are being put together jointly by community mental health programs and community service boards. And an example of that in Washington County, Oregon, has set up such a program. And again, it's fairly new, but it's shown a lot of promise, and almost immediately it had a very large clientele that was coming in on this walk-in basis. So a couple of examples there.
That's excellent. Dr. Thomas, have you seen anything along those lines down in your part of the state?
This is fascinating, and to hear what's happening over on the West Coast. Yes, the Department of Behavioral Health here in Georgia has established what they call 23-hour observation units, which are, in a sense, kind of like walk-in crisis centers. The function here, I think, is slightly different. I think the value to the hospitals is that they divert people away from emergency rooms and save hospitals on the usual substantial cost of having people in emergency rooms. But the idea is that these should be staffed with qualified staff who can triage the patient, determine who really does need to go into, for instance, a crisis stabilization unit or a hospital, and those who can be restabilized safely in the community. I think this is a very interesting development.
Well, it's excess capacity in some ways and an excess need. If we could just link them, that could be great. Dr. Vincent, I want to shift gears with you here and talk about something you alluded to earlier, which is early intervention, school-based care. What are some of the successes and challenges you're seeing as in your profession as you try to move further upstream and deal with prevention and getting to the young people and other people before they get into a crisis situation?
I think there is a growing appreciation for the benefit of partnering with school systems, just because that's where the kids are. And it's another place, sort of similar to juvenile justice, where kids kind of have to go. Whereas with primary care, with mental health, they may not choose to be in those spaces, but you have to go to school. And if you get in trouble, you might have to go to DJJ. And so what we see in Georgia is that compared to other states, for a long time, we really haven't offered the same level of emotional and behavioral supports to kids in schools. But schools are asking for more help. They're receiving more help. And you have things like the APEX program that's been successful that we just have to continue to support and to grow. But I think it's a great opportunity, and we've had some successes. Mm-hmm.
Sending the question back to you, Dr. Thomas, are you seeing, are you involved in some, I know you have school programs or aspects of connections to schools, but is it on the population health management and prevention side, or what do you see as challenges and opportunities?
I think Dr. Vincent is absolutely right. And actually, if I can take a step back, it does work towards prevention, although I'd like to make a separate point about that. School is an enormous advantage in terms of access. It's where the children are. We can get services to children in the schools who would not otherwise attend the clinic for whatever reason. Often because parents are unable or unwilling to bring them to our clinic. So providing services to schools is very helpful. I'm guessing we can talk about telepsychiatry.
Absolutely, it's a good point to bring it in.
But in terms of prevention, I would mention homelessness. and providing safe and secure housing in neighborhoods that don't exacerbate the problems the kids already have. Homelessness is not just an urban problem, but it's more hidden in rural areas. But we have a lot of kids who are vulnerably housed in our school system here in Ware County. It probably runs to about 450 in a county which has perhaps got 40,000.
And that's such a great point about home environment. And you may have kids who technically aren't homeless, but whose mothers have a choice between being homeless and housing insecure or staying in an environment where the child may be exposed to traumatic events, either done against the mom or against the kids. And so that is a huge issue, and I'm glad he raised that.
Are there, and this is for anyone, are there other ways or other pools of potential patients and people you can serve other than in school settings and in court settings? Are there other ways of casting a broader net and moving the needle, so to speak, in larger population groups other than schools and drug courts?
So let me comment on that. First, a few more comments on schools. So one of the things we're seeing nationally with regard to schools is much more connection and outreach between community mental health programs and schools. In many, many places, community mental health programs are now placing some of their staff directly into schools to provide services, as Dr. Thomas and Dr. Vincent were describing. Another feature of schools is the effort of local communities to address what are called the ACEs, the adverse childhood events that children experience. And you have the advantage in Georgia that you have the Centers for Disease Control right there, and the ACEs work nationally is done at the Centers for Disease Control. So the schools in Georgia could participate in some of that work, and if you identify particular populations or groups or areas that have particularly high adverse childhood event scores, meaning the child has been exposed to various kinds of trauma, it could be physical abuse, mental abuse, sexual abuse, other types of trauma, then particular interventions are available to address that before that translates into a severe behavioral health problem, which it will if the ACE is not addressed. So I think there's a lot of good work going on in that area that could be developed and replicated in Georgia. I want to go on and talk a little bit about a different population we haven't said much about, and I'm sure it is a problem in urban and rural Georgia just as it is elsewhere nationally, and that's the problem of incarceration of persons with mental and substance use condition in city and county jails. So if we look at that issue nationally, so tonight there will be about 730,000 people in the county jails of the United States. 3/4 of those people, more than 500,000 of those people, will be people who have primary mental health and substance use condition, all the types of things we've just been talking about. So we have another population out there that I think we aren't serving very well, either in our urban areas or our rural areas. And again, there are programs being developed in these areas. My sister organization here, the National Association of Counties, has a program called the Stepping Up Program. The purpose of the Stepping Up Program is to get county boards to do a formal resolution saying we recognize we have this problem in our county jail, to then do strategic planning, to do the convening across the health, social service, and criminal justice leadership in the county, and then to move the agenda in some way. We have an initiative here where I've got a number of pilot counties, and my effort, unlike the NACO Stepping Up initiative, is to do what we can to improve the county behavioral health system so fewer people fall through the cracks in the first place into jail. And so to do that, you have to strengthen your crisis response capacity, your care coordination capacity, and as Dr. Thomas said, your social wraparounds for these populations. So I think there are large opportunities of working with the incarcerated population here as well, and also to move it upstream into prevention and do more work to prevent that population from going there in the first place. If fewer people with those conditions were in jail, the counties would be spending less money on health care in the jails. Counties spend $70 billion a year on health care in the jails, 75% of which goes to these populations. We could better spend that money in the community, improving our schools, improving our service delivery through the community service boards, and so on. So I think there's huge opportunities in different population groups here. That's
an amazing point. Do you want to respond, Dr. Vincent?
Well, just tying them together, so the school to prison pipeline, right? We know that if schools don't catch those kids with reading disorders and they drop out of school and they become truant and they're hanging out on the corner, then it doesn't lead to good things. And so they really are connected. And I was medical director for a competency restoration program at Fulton County Jail for a few years, and it is striking what an overrepresentation there is of learning disabilities in addition to mental illness and substance use that you see in jails. And so if we do a better job at catching those kids, giving them the interventions they need so that they can continue through school, we will help address those issues. And so they're really very closely tied.
Dr. Thomas?
A couple of points really on this important topic. One is accountability courts. I think Governor Deal in Georgia has been a champion for the development of these programs. They are very effective. A committed judge backed by good treatment services can really turn lives around for people who've got felony convictions for drug offenses. The other piece of that, which is, I think funding for drug courts, accountability courts, is going to become an issue eventually. At the moment, a lot of them are grant funded. The other issue is education for law enforcement, and we have done a lot in Georgia with crisis intervention team training, where community service boards often assist law enforcement locally in providing training to law enforcement officers. It's the 40-hour training, the full one. And that does several good things. One is it establishes relationships between the community service board professionals and the law enforcement officers, so that when a law enforcement officer faced with somebody sort of walking naked down the median of the highway doesn't automatically reach for his gun, but maybe calls up the local mental health provider and gets a mental health intervention instead.
Excellent points. I think we're starting to get closer. There's a couple of other issues I wanted to, and all of these issues we could just keep drilling into them. It's fantastic the insights you're bringing in, but we do have an opioid crisis and epidemic really, and I don't think we can leave here today without getting your thoughts on how that's impacting in the rural areas and what we might do about it. Maybe we can start with Dr. Vincent, who I know specializes in opioid, specializes in adolescent and child services, but I've understood that it's a problem even with children and their young teenagers. So what are you seeing or thinking about these days, Dr. Vincent, in that regard?
Yeah, as it relates to the opioid crisis and the child population specifically, so of course you have the kids who may be using themselves, but what we're seeing a lot of is the kids of the parents who are using. And that could be that the parent is using and they're not able to parent as well as they should. It could be that the parent is completely absent. It could be that the parent is incarcerated. It could be that the parents get divorced, and then there's subsequent economic instability in the household because of that. And so there's the opiate, but then there's all the ripple effects that come with substance use disorders, and children are really vulnerable to those because they have less agency in their ability to counteract the negative effects on their lives.
I'll throw it open to Dr. Thomas, Dr. Manderscheid.
So let me respond a little bit. So on opioids that Dr. Vincent was talking about here, so if you have a child in a family where the parents are doing drugs or the parent is doing drugs, the probability goes way up that that child is going to become engaged in this as well, sometimes purely by happenstance, where there'll be a bottle of pills laying there, and the child will take 10 or 12 of these pills, and that will kill the child. So when we talk about, the 150 people a day we are losing to drugs, a significant portion of those people are children who have never taken drugs before but are exposed to the availability of those drugs in their homes and so on. So I think, the point that Dr. Vincent is making is very, very important. On the treatment side, I think a point that Dr. Thomas made about integrated care is very relevant here. So because like the mental health issue, the opioid issue is still what I would call a growing epidemiology. So we lost about 66,000 people to death due to opioids in 2016. We're expecting, when we see the numbers for 17, that they're going to be even higher, and the numbers for 18 will be even higher than that. So we are literally in the midst of an epidemiological crisis on opioids. Now, we also know that in order to treat opioid addiction, you need to combine medication-assisted treatment with various forms of therapy. And in order to do that, again, it points to the need to bring together behavioral health care and primary care so that you have the capacity to have physicians who can administer the necessary medications for medication-assisted treatment, but also have available the behavioral health people who can do the various forms of therapy that are needed with people so that they can move toward recovery from opioids. So a very, very significant, difficult issue, and I would say just as difficult in rural areas, or even more difficult than it is in urban areas. And living in a rural area doesn't protect you from this. In fact, it may actually expose you to this.
Dr. Thomas, your thoughts?
Yes. Dr. Mandelscheid's really described the proportions of the crisis very well. We have started using medication-assisted treatment combined with groups and therapy and case management as part of the state-targeted response to the crisis. And this is proving very effective. Our caseloads are growing enormously. One particular difficulty faced by rural providers, of course, is the distances people have to travel to, for instance, attend the twice-weekly groups and the various other sessions that we combine with the medication-assisted treatment. It's true that this can be done as part of an integrated service with primary care providers. We are, in fact, have physicians who are certified to prescribe Suboxone and other medications for medication-assisted treatment in-house. So we are actually handling this as a service just by the Community Service Board. What I foresee as being a problem is the cost of the medication for the uninsured, because a lot of people who have opioid addiction don't qualify for insurance. If their addiction has sort of prevented them or led them to lose their employment, of course they've lost any employment-related insurance, and they often will not qualify for Medicaid or other programs. So again, I keep coming back to costs. There needs to be some way to get funding to the uninsured for these programs to work and to be deliverable. That's my piece on that one.
There are two more topics I'd like for us to get to, and I think I can kind of combine them. And again, I'll throw it open for whomever is interested in picking up the ball and running. The problem you allude to, Dr. Thomas, which is the difficulty, particularly in rural settings, but also in urban settings, of getting adequate coverage from qualified providers. We have more demand than we have providers. As we said earlier, in rural areas, that's compounded by the great distances and the disproportionate number of people who don't have the resources to have a car or get an Uber or a train or otherwise get to the services. Telehealth, telemedicine has become something that my law firm and consulting practice works with this day in and day out. We represent the telehealth providers as well as those that are interacting with them, and we see it almost hitting a tipping point, I'd say, in the last 24 months. Where is the state of play with telehealth and behavioral health space, particularly as it applies to rural areas, and where do you see it going, and what could be done to spread it faster and more effectively?
So let me give the national perspective on this. So for a long period of time already, the U.S. Health Resources and Services Administration has maintained and developed a national telehealth office. And that telehealth office has, helped advance the technology in this area. It's also provided demonstration grants out in rural areas to implement this and so on. So I think that track needs to be enhanced, and part of our work, I guess, at the national level is to do strong advocacy so that what that office does can be strengthened and it can reach many more rural communities, rural counties, and so on. So I think there's a huge need to do that. Another piece of this thread is the whole issue of whether we actually have high-speed internet capacity out in these rural areas. And when I go to the NACO meetings and I go to the Rural Action Caucus, that issue always comes up. And I remember, in fact, I believe it was a representative, a county official from Georgia, speaking up at one of those meetings last summer saying, well, she has high-speed internet in her office, but the children don't have high-speed internet in their homes, and they don't have it in school. So when they want to do homework, they have to come sit outside her office and use the Wi-Fi. Well, we need to do a lot better than this, not only for the schools and training people, but also for the implications of that technology, as you're saying, for health delivery and behavioral health delivery. So there needs to be advocacy on that side as well, I think, to move the agenda more. And I think most county people I know and most community service board people I know are pretty open to the use of technology if we can get these tools into their hands.
Dr. Thomas, I know you've been very active with telehealth in with your community service board. How is it going, and what do you see as the future of it?
In addition to the points that Dr. Manderscheid has made, which are absolutely on target, I would say that we are now currently bumping up against regulatory and funding restrictions. Let me do with the funding ones first, which is that the Georgia State Medicaid plan does not provide for telehealth services for any provider except a psychiatrist. There are a few small exceptions for people whose first language is not English, but by and large, for instance, we can't have a licensed social worker or a licensed counselor deliver a behavioral health assessment via telehealth technology. That's not reimbursable. So that's one thing that would be very helpful, because we can staff a small rural town with a clinic which has a nurse and a receptionist, maybe, and if we could just use telehealth to get a licensed social worker to come in via that technology to deliver a behavioral health assessment or to deliver a therapy session, that would be enormously beneficial in improving access. The other problem with telehealth is that there are a number of regulatory restrictions to its use. In particular, its use for child psychiatry. Now, child psychiatry is a particularly it's a profession that's in particular short supply, and the only board-certified child psychiatrists that Unison can engage with actually live far away from our area, and they provide their services by telepsychiatry. Unfortunately, there's a number of rules, state regulation, and also federal Ryan-Haight Act that limits the use of telepsychiatry for the prescription of ADHD medications, which very often children will be in need of. So there need to be some regulatory changes too, I think, for us to realize the full potential of this important technology.
Thank you. Dr. Vinson, from your perspective as a provider, and one thing a lot of lay people wonder is telehealth services in the behavioral health arena effective? Are they getting a lower standard of care if they're interacting with a behavioral health provider via a television screen?
Well, we know that people can get good outcomes through telehealth, and that's been studied, and we found that that's the case. And we found that it's the case with child and adolescent populations as well. And really, this generation is more used to interacting with people through a screen than in real life in a lot of ways. I will say that when it comes to mental health, especially when you're talking about the folks at community service boards and those sorts of things, it is really rare that a medication in and of itself is going to make them better. And while psychiatrists are trained in therapy, the reality is often in these public sector systems, they're relegated to the role of prescribing medicine. And so it absolutely is important that people are able to receive therapy services as well in order for them to really, really get better.
Well, I'm being told I've just got maybe 1 minute left, and so quick question to everybody, and it's an important one. How do we get more people? How do we get more providers? We have a shortage. What can we do?
So my 10 seconds. The National Health Service Corps has been expanded, and the number of behavioral health providers in the National Health Service Corps has been expanded. It would seem to me many areas in Georgia would be eligible for placement of providers trained through that system as part of their federal payback obligation.
Child psychiatrists are not included in that, and that is something that we have been advocating for years on the Hill. But I agree, that would be great.
Dr. Thomas, parting shot?
The J-1 visa waiver program that allows for foreign medical graduates who've completed their training in the United States to stay on and provide services in rural areas. This is a very helpful program for areas like mine, where we currently have 2 J-1 visa waiver psychiatrists working for it.
Well, I think I need to wrap up now, and as I conclude, I want to thank WABE for the use of their wonderful studios and teams. I want to thank the Georgia Healthcare Foundation and the University of Georgia, and particularly Dr. Fazil Khan from the University of Georgia Law School, who helped us at Bowling & Company pull this together. And I really want to thank Dr. Ron Manderscheid, one of our speakers this afternoon, Dr. Sarah Vincent, and Dr. Glenn Thomas, who are such great experts in their field and have also been very articulate today about the challenges and opportunities that rural areas are facing with behavioral and mental health challenges. So thanks, everybody, and everybody that joined. We really appreciate you being with us today. This will be available for you from a link from several different sources. If you didn't get to stay for all of it, or you missed some of it, or you want to hear some of it again, we'll send out an email with those links very soon. Thanks for being with us. Thanks, everyone. Bye-bye.
Take care.